Whoops. I'm going to ask you not to do any charting, which I don't see any charts, and put your phones up, and it's time to get started. Okay, here's the problem. Well, let me first introduce myself. I'm Bonnie Flemister. I'm a geriatric nurse practitioner, a wound ostomy continence nurse, dementia care specialist. But all of that is that I really don't sit in some ivory tower and make up rules for y'all to do. I know what you do. Okay, I mean, I've worked with you, do you hear me? I've worked with people just like you in nursing homes. So I know what you have to do every single day, okay? The problem is that, I always want to say DADS, and it's not that
Right,
anymore.
right.
It's Health and Human Services of Texas came in and found that you had a significant number of medication errors. So part of that correction is for me to come in or someone to come in and do what's called directed in-service training. Okay. So what we want to cover today is I'm going to help tell you what a medication error is. You may think you know what it is, but it's probably more than what you think. We're going to identify what significant medication errors are. We're going to talk about nursing measures to prevent those medication errors, and it's the usual 6 rights that have been pounded in your head in nursing school, I'm sure, and then explain why reporting medication errors improves resident care. So the medication errors are this: 10 to 18% of all errors that occur in the hospital, injuries, are due to medication errors. There's between 44,000 and 98,000 people die, do you hear me? Die in the United States every year due to medication errors. It is the 3rd leading cause of death. That was on your test, okay? 3rd leading cause of death: cardiac, cancer, medication errors. Does that tell you how important it is? And I think part of the problem with medication errors, especially in a nursing home, is because you have the same patients, the same medications, and it gets to be routine. And anytime you have a routine, you begin to stop paying quite as much attention to it if you had a new patient or a new list of medications. Okay, I'm a nurse, I get it. The other thing is if you can imagine that a Boeing 747, look at the top of that. Look at all those seats. If one of those planes crashed every single day and everybody on the plane died, that's the equivalent of the medication errors that we have in this country every year. Okay? Now, if you knew that there was going to be an airplane crash in the United States and everybody was going to get killed on that plane every single day, you'd be a little worried about flying, wouldn't you? Okay. The reason why the airplanes are safer is because they have procedures and they follow them. And so we in healthcare need to follow that example. So a medication error is a medication or a biologic. Okay, a biologic is something like a vaccine or what your immune-compromised patients take, like arthritis. Okay, so you has to be in accordance with what the order is, what the manufacturer says how that drug or biologic needs to be prepared. Okay, and administered. Okay, not just what the physician says, but what the company that makes that drug says, and then accepted professional standards and principles to which you are held accountable. If you're nursing, there are certain standards that you have to meet. If you're med-aid, then there are certain standards that you need to meet, and those standards are what you're responsible for. The interesting thing is I have a master's degree, I'm a nurse practitioner, and you are held to the same standards, and I am held to the same standards that you are about distributing medications. We're nurses, okay? So a medication error is any preventable event that causes or leads to inappropriate use or client harm while the medication is in your control, when you actually are controlling it. So the adverse consequences are the U.S. Department of Health and Human Services says 1 in every 3 skilled nursing facilities has an adverse event or a temporary harm event. 37% of these adverse events were related to medications, okay, and 66% of all medication-related events were preventable, meaning we did them and we shouldn't have. So the consequences of medication-related adverse events include prolonged, they have to stay in the skilled facility longer, they may have to go to the hospital, they have to have different interventions, permanent harm, and even death. So CMS, and that's where we get our reimbursement, okay, and so the facilities are required to be in compliance with Medicare and Medicaid at all times, every time, every day, every minute, for the health and safety of the residents. When a facility fails to maintain that compliance, then for Medicare and Medicaid, then they come in and have remedies. Now, I honestly had to look up what remedy meant, because to me, it means to fix it. But the way they fix it is, some of the possible fixes are the facility has to pay a penalty, money, or they have to have a directed in service, which is why I'm here, okay, or even and have a directed plan of care. Come on in and sit down.
Bring your chair back here if you're too close.
Just wherever you want to be. But remember to sign in and take your pre-test, post-test. Just sign in. So, there's kind of a game of administering medications, and you'll see where the problems could be. The physician orders a medication, okay? Now, we're assuming that he knows or she knows what they're doing, right? And then they write that in the chart, or it's a verbal order to the nurse, and then the nurse or the doctor could call it directly into the pharmacy, which would mean his nurse, which a lot of times it's not a nurse, somebody just working in his office or her office, okay? And then the pharmacist interprets the order and dispenses it, and then the nurse follows through and either hangs the bag or passes, gets the medication. Now you can see there's a lot of transition between person to person, and it's kind of, remember that game we used to play where you whispered something to the person next to you and passed it on, and a lot of times it came out nothing like it you thought it should. So poor communication of medical information at the transition points, doctor to nurse, nurse to pharmacist, so forth, is responsible for 50% of all medication errors. Just talking to each other, just passing the information, and 20% of adverse drug events. A lot of times we don't know where the breakdown was. We don't know whether it was in a person to person or just the system. So a significant medication error is anything that causes the resident discomfort or jeopardizes his health or her health. It's also can be based on expert opinion. Okay, so there's nothing set in law. This is significant, that's significant, because it matters what the resident's condition is. Okay, how sick are they? How does it apply to that patient? If you have a heart patient and don't give the heart medication, then that's pretty significant. And it depends on the drug category, and we'll talk about that later, what the dangerous drugs are. And then the frequency of the error, if you do it over and over again. So an example would be not giving a laxative. Now that wouldn't make any difference to someone who doesn't suffer from constipation. They might be slightly uncomfortable. But I honestly did a case recently where they missed the laxative and the patient went for 7 days without a BM. Okay, ended up in the hospital. So definitely a significant, and then there's non-significant errors. So up to 25% of look-alike, sound-alike errors are due to drug name confusion. Okay, and up to 33% are due to the way they're packaged. So if you look, I don't know whether you can see, but look up at the corner of those incidents. Same size bottle, same color type, same color top. You look at that R, is that for regular? Okay. So a lot of times the confusion could be with illegible handwriting. If any of you have been around for a while, docs don't always write very well. And then incomplete knowledge of the drug names. New products are always coming out. Similar packaging or labeling. Okay, look at that. Look at all the insulins. Humalog, Humulin, Novolog, Novolin. I can see looking up there and grabbing them, especially when they all have an orange top. Okay? And then similar clinical uses, well, they're all insulin. And then similar strength and dosage forms. So what are usually considered medication errors is if it requires discontinuing the medication or you have to modify the dose. If they require hospitalization, a result in a disability, require treatment with another prescription drug, they result in a cognitive deterioration or impairment, are life-threatening, or could result in death. Those are all down the line, no contest, significant medication errors. So this medication error rate, it looks complicated, but it's not, but it's just the number of errors that are observed by the observer for the doses that were given and the doses that should have been given, and multiplied by 100. Okay. So anything over 5%, you get the tag, which is the 759. So you all know what the components of an order should be. It should have the resident's full name. It should have the date and time the order was written. And I find that I read some law cases, and I find that we don't do this very well. Okay, we'll put the date, but we don't necessarily put the time. The medication name, the dose, the route, how often you should give it, and the signature of the physician eventually. So nursing measures, you should make sure that your medication order contains all 7 of those things I just talked about. Clarify, clarify, clarify. It's your license. Clarify. Minimize the use of telephone orders, which I know, been there. How do you do that? Okay. But the best thing to do is when you have a telephone order, repeat what you thought they said and have them verify that. Okay. And then if nothing else, if it's a sound-alike, Novolin, then ask them to spell it. It's your patients. It is your resident that you're responsible for. And then check the medication administration, check your MAR to the original prescriber order, whatever your agency says. Clarify your orders. Look at the prescription. Honestly, look at it and see that what's the handwriting. Is there anything in here that's unusual? Is it non-standard? Are there abbreviations that you're not sure of? Is there incomplete information? Stop and look at that prescription and think about your resident. Does this apply? Is this the right kind of medicine for this patient? You talk about allergies or interactions. Okay. Verify appropriateness of the medication and the dose. Consider computer alerts. Do you have computer alerts? And then highlight unusual dosage forms or strength. And then check the expiration date. I've also done an in-service because nobody checked the expiration dates, and there were several expired drugs on the cart. Okay. So you need to have some kind of a routine. Who checks the expiration dates? the afternoon nurse when she gives, whatever. Just have a system. Okay, and make sure your system is what your policy says. Okay, your medication delivery and labeling systems vary. Okay, medication names, with any luck at all, you can have the generic and or the brand name. You need to have the prescribed dose strength, expiration date, resident's name, route of administration. The medication should be labeled with or accompanied by appropriate instructions. For instance, if you're supposed to shake it, it should be on there. If you're supposed to mix it, if it's supposed to be room temperature, if it's supposed to be refrigerated, you need to check all those things, and expiration date if applicable. So the Texas Board of Nursing says that LVNs work within their scope of practice, and the LVN, based on knowledge and clinical judgment, is expected to know the rationale and effects of the medication and treatments that they're going to give. Simple. Accurately and completely report and document administration of medications and treatments, and to clarify any order. And if there's an order that comes in and you're not happy with it, get back with whoever prescribed it, and if they give the explanation and it still doesn't sound right to you, don't give it, and tell the prescriber why. Okay? And document why you're not. Nursing responsibilities. Know the rationale for and the effects of all medications that you give. Refer to authoritative sources, okay? If you've got a PDR out at the nurse's station, make sure it's up to date. A 10-year-old one is not going to do you any good. I think most of us are checking online now, aren't we? Yeah. And then questioning a drug order that's unclear or appears to have an order. Refuse to administer a drug if there's any reason that you believe it to be harmful. Okay. Accurately and completely report and document any administration, and monitor the residents' response to whatever you give them. Okay. And then that's an opportunity to family. Know the information about the medication. You need to know what the drug is supposed to do. You need to know what it might do that you don't want to happen, or it could be even a side effect that's beneficial, and what the appropriate dose is. Absolutely, positively, any drug you give, you should know what it's supposed to do, should know what the side effects are, and you should know what the dose should be. There are age-specific considerations. There's a lot of considerations dealing with the elderly, and that's a whole different talk, but look those things up. And then self-check for accuracy. If you're the only one given the drugs, okay, sometimes it's helpful if you check the label with this hand and then put the directions or the drug in the other hand and read it. Okay, just anything to change it. Sometimes just the delay in self-checking. You check with this hand and go ahead and count the pills and then check with this hand again. But anyway, recalculating using a different process. Okay, if you divide this, then take that number and multiply it and see if you get, how to do all that. Nursing measures to prevent, use the 6 rights out of 10. There's now 10 of them. But the first one is make sure you got the right patient, right medication, right dose, right time, right route, and right documentation. Then the other new ones are for the right reason. The resident has the right to refuse, have the right education, and the right evaluation. Okay. So tell the patient the time of administration, what you're doing, and why it's being administered. Y'all can do that with those who know, can absorb that or understand it, and then the others, you can do it anyway. It's a good habit to get into. I'm giving you your blood pressure medicine so we can keep your blood pressure normal, okay? A patient may question the drug or dosage, reconfirm the drug order in the chart in the MAR. Okay. Provide an opportunity to do medication teaching. The 3 checks, you should check that 3 times. Check the label, On first contact with the drug when you're removing it from the medication box or the cart. Check it. Check it against your MAR. As the medication is removed from the package, from the bubble pack, or if you've got a bottle that you're taking a dose from, you check it before measuring, before pouring, before counting, before withdrawing. Check the prescription label again against your MAR. That's one of the things that I think we forget to do. We know what's on the MAR, okay? I don't need to check that. Check it. And then final check should occur at the resident's bedside before the medicine's given. The right drug. Be aware of distractions. Oh, y'all, I know. You're standing at that medicine cart and you've got family coming, you've got residents coming, you've got housekeeping wanting you to move while they sweep around. I mean, there's all kind, I know, okay? But try to do that. Don't multitask. If you're passing drugs, pass the drugs. Use barcoding if it's available. I don't know whether you have that. Be knowledgeable about your drug's actions, indications, and contraindications, and be extremely alert about your high alert medications. Be sound alike, look alike drugs, and we'll go over some of those. And don't accept drug name abbreviations. For instance, if you've got an order for morphine sulfate, it's not just MS. Okay. We all know what MS is, but spell it out. Okay, high alert medications, that's typical of a medication thing. I've done Institute of Safe Medication Practice has a hyperlink. There's the top 5 drugs involved. Remember the abbreviation PINCH, P-I-N-C-H. Potassium, insulin, narcotics, Coumadin, heparin. Okay. Any of those 5 drugs, be careful, be careful, be careful. And then there's several drugs, names for example, Tegretol and Toradol. Hear how you could mistake those? Paxil and Plavix. Use your tall man letters. Do those come on your medications when you get them from the pharmacy, the tall man letters?
Some of them.
Some of them. That might be something you want to talk to your clinical pharmacist about. And then know both generic and brand names. Right route. Consult your drug information source, where this is supposed to go and how it's supposed to go. Don't accept incorrect abbreviations. We've all seen SQ and SC for subcutaneous, and what's preferred now is subcut for subcutaneous, okay? Because SC could be mistaken as SL for sublingual, SQ mistaken as Q for every. It could be, you can read all of those, but you can see what the mistakes could be. Example, and be careful of your IVP and IVs. Do you all do very many IVs here?
We do some, not
Okay.
a lot.
Yeah. PICC lines are becoming more and more.
They are. We have one in the building.
Uh-huh. You may need to change or clarify forms or routes of the drug. You have to stop and think, I'm giving this patient, are they on MPO? Are they supposed to go somewhere later this afternoon and get lab? Or you're passing the drug and they're supposed to be MPO before the lab comes. Okay, pay attention to that. You need to check and see if their inability to swallow. You need to pay attention to your nasogastric or surgically inserted tubes. And then, of course, your time-release drugs, enteric-coated drugs. The right time. Order should include how often you should give it. We all know an hour before or an hour afterwards. Use safe abbreviations, QD, QOD. Instead of QDay, just write daily, okay? And if it's QOD, write every other day, because that could get messed up really easy. So the right dose, carefully read and clarify, don't accept illegible. I know I'm going over the same things, but don't. Now let's talk about leading or trailing zeros. Don't accept U or IU, what's preferred, just write unit. And recheck label 3 times. Now, inappropriate use of zeros. If you have a dose that's less than 1, always put the 0 in your decimal point and whatever the drug is. Okay. Just don't put that 0 there, because that period, that decimal point, can get lost to the transition, and you're given 25 milligrams instead of 0.25. And then never follow a whole number with zeros. I don't know why we do that. But right dose. Have 2 nurses check high alert medications. Okay. If you're given insulin, if you're given narcotics, grab somebody and have them look at the label with you. I don't care how many times you've done it, do it. I would never, ever, I would never give an insulin dosage without having somebody check beside me. It just takes a second. Consult your drug references. Consider developmental age of the client, which you need to do that and accurately do your picking. Document immediately after the administration. Don't document that you gave a drug before you gave it. I know you're standing right there and you've got this stuff in front of you and you're just going to walk in the room and give the pill, but trust me, anything could happen between leaving that drug cart and getting in the room. Okay, you could go in and your patient's not breathing. You could go in and the roommate's on the floor, and you start taking care of things, and then the drug doesn't get given and it looks like you did. Okay. For the right reason, you must ensure that that's appropriate. Administer and you don't give antibiotics for viral infections, and giving a sedative to a patient who appears sedated. Okay. The right form, many medications are available in different forms and they go by different routes. Some medications come as tablets, capsules, caplets, syrup, suppositories, and ampules for IV. Okay. Just because it says Tylenol, okay. Tylenol comes in every shape, form, and whatever, okay. Some meds should not be crushed, you know that. Right to refuse. The legally responsible party, family member, guardian, has the right to refuse any medication, okay. Do you see I have underlined legally responsible? Some family member can just come in and say, don't give my mother that drug. I looked on the internet and it causes cancer in mice. Okay?
Yeah.
You have to, who's responsible? And unless that resident has been declared legally incompetent and someone else has medical power of attorney, you need to be very, very careful about refusing to give a drug. Inform the responsible party of consequences of refusing. If the resident says, I don't want to take that, you know, okay, if you don't take that, this is going to happen, or this may happen, okay? And then guess what? You verify the responsible party understands all those consequences, okay? And then notify the physician that the prescription medication wasn't given, and then guess what? You document. Do not ever forget to document the refusal. I would write down exactly what whoever did the refusing and what your response was. Okay. Right response, once the medication is administered, monitor the patient. Okay. The right medication administration involves an evaluation of the effectiveness. Think about it. Why are you giving this medicine? is it working? Did it do any good to give the medication, or did the resident respond in a way you weren't expecting? Unless you go back and check, you'll never know those things. And then crucial for some high-risk medications such as anticoagulants, they could bleed out, antiarrhythmics, they could go into some kind of a cardiac event, or insulin, and certainly pain medications. Even if it's just Tylenol. Just Tylenol. If you're giving it for pain, go back and check and see. And document it. There was a study done about adverse drug events, and they found that inadequate patient monitoring after medication administration occurred in 36% of all drug events. Okay. Almost 4 out of every 10 drug errors was because we didn't go back in and see how the medication was working. Okay? So this is, I'm going to go through this because this is what state said I had to cover. Okay? Eye drops. Okay, clean the eyelashes. That's something that I'm not real sure I would have thought to do. But anyway, clean their eyes, unless I saw it was goopy, But clean their eyes, then you follow the manufacturer's product. Remember, that amounts to a drug error if you're not giving it the way the manufacturer said to do it. And then make sure you got the correct eye, and confirm the medication is in full contact. And sometimes just pinching below the eye like this will open up that conjunctival sac. Don't allow the bottle to touch the eye. See? Then a transdermal patch. Y'all, we need to be careful of fentanyl patches. Okay. The way things are going now about opioids and fentanyl, I'd almost make sure that somebody saw me dispose of that properly. Okay. I mean, that's ahead of the game, but I'm just saying I would seriously consider when I took a patch off that it was disposed of properly. Okay. And then select a new site that's on a flat surface, chest or back. If the patient's confused, put it in a place where they can't reach it. I also know that if you're using a transdermal patch, you can't put it on a skinny old 90-year-old lady. That you need some fat tissue beneath that patch in order for it to be distributed evenly. The skin should be intact, no irritation, avoid hairy areas below. And if it needs to be cleaned, use clear water. Okay. Because a lot of our soaps might have lotion in them and then you don't get good contact. Remove the patch from the pouch and peel off half of the Proactiv liner and then put the adhesive down and then pull the other half off. Okay. Because if you do both of them, it's so easy to get them stuck together, and then boy, trying to write off why that got thrown away is a lot of time. So metered inhaler doses. Okay, there's basically 3 techniques: an open mouth attack, using a spacer. Do you have anybody that uses spacers here? Sometimes that makes your life a lot easier. Okay, so think about it. If you've got a resident that's really hard to get that, And the other thing is a lot of the inhalers have steroids in them, and they can get a fungal infection really easy in their mouth, and a spacer would prevent that. But anyway, there's using a spacer or the closed mouth technique where you actually put the inhaler in their mouth. The most effective way, you shake the container, the most effective way is to actually hold, if you're using an inhaler, or somebody who can understand what you're saying, if you hold that inhaler away from the mouth and blow, and then have them suck in, that's much more effective. Okay, I actually had an ENT teach me that. And then if more than one puff is required, try and get it 5 minutes between. And I know we're in a hurry, but usually Usually our residents have more than one drug, so you can do the inhaler first, then give them another pill, or do something else, and then give the second dose of the inhaler. But if you do 2 in a row, they don't get the benefit of 2 doses. You've just got 1 big dose. Insulin, I am not, just follow the directions. Check it, remove the cap, push the needle in, and then fill your syringe and insert it. And the one important thing is make sure you're going in at a 90-degree angle. It's not sideways, it's straight up and down into that skin. Okay, and then this says that you release the pinched skin and then count to 5 and then pull the needle out. I've never done that, but it's a good idea. Okay, so if you pinch the skin, release it, then pull the needle out. Okay. Then that gives it a chance for it makes sense, it gives a chance for the...
Gives a chance to spread so it
Yes.
doesn't bubble back out.
Mm-hmm. So nasal medications, beg your pardon?
I have to do mine like that.
Uh-huh. Some of us know a lot more about giving insulin than others. You need to provide tissues and ask the resident to blow their nose before you put the nose drops in. Have them sitting back or lying back so you can have gravity help you with the nose drops. Ask them to breathe through their mouth and hold the dropper about a centimeter around the nares. I did not know that nares, N-A-R-I-S, is singular and nares means both. Okay. Draw the fluid into the medication drop, enough for both nares. Don't ever return the excess back into the bottle. Don't squeeze it back in there, and have the patient hold one nostril closed as you do the one thing. Okay, medications in a feeding tube. You release the G-tube clamp and you verify the tube placement by aspirating stomach contents. I do not know what your policy is here about, do you put that back in? Do you put the gastric contents back into the stomach? No, you dispose of it. Make sure that's what your policy says. Okay. And then you note the volume, and then clamp the G-tube and remove the syringe, and you take out the plunger. And make sure you hold that up. Been there, done that. And then you reattach the syringe and unclamp the G-tube. You can just pinch that together. And then release the tubing and let the water flow by gravity to flush it. Always flush a tube before you give the medication. Okay, because now if you've aspirated, now you got a tube full of gastric contents. So you need to get the think about it, you need to get the gastric contents out of the tubing. And then pour the diluted medication into the syringe and release the tubing to administer it. And if you're giving more than one drug, flush between. Don't just put one drug, another drug, and another drug. The drug, flush, drug, flush. Error reporting. Errors reporting and cause analysis are important tools to identify the major causes. Why did this medication error happen? What happened? Because it's not meant to be punitive. They don't ask you to report drug errors because they want to punish you or fire you or read you out. They want to find out why it happened. Okay. And otherwise, if you don't say why it happened, you're going to make the same mistakes over and over again. And I think that's one of the problems. And then the other thing, near misses. I think these are important too. If you almost make a mistake, but you catch it, you need to tell why that almost happened. Because if it almost happened to you, it could almost happen to somebody else and they really make the mistake. Okay. So near misses are really important because that's how you find your safety lapses. And a nurse, when a medication error has been identified, should try to determine how the error was made in an effort to keep it from happening again. That's your whole purpose. If there's a mistake, how do we keep this from happening again? So the summary is the long-term care facilities must provide routine emergency drugs and biologicals to its residents. The facility is responsible for those drugs and biologicals being here. And then accuracy in acquiring, receiving, dispensing, and administration of medications and biologicals for each resident. They have to have those for each resident. Your responsibilities are you're liable for your actions, what you do, what you omit. And for those duties that the RN may delegate to others, they are personally responsible legally, morally, and ethically for every drug that's given in this facility. So those are the resources that I used. Do you have any questions? I want to thank you for your time and attention. Now it's time to take your post-test.